Okay, welcome everybody to Fitfoot U, and today I'm honored to have Richard Blake talking about his book, Practical Biomechanics for the Podiatrist, which is a great lay piece for students. And also honored to have Dr. Stephen Pribut, who's worked with me in the Academy and was previously on the editorial board of Runner's World. And you guys know each other from way back. So I know that Steve, you've got a lot of experience and questions, and I want to get right to it. We had a chance to have Richard in the previous segment kind of talk about why the rationale behind the book, and now we can dive a little deeper into a couple pieces of it. So I'm going to be quiet and let you two guys take over, and welcome again.
Well, thanks.
Thanks.
I would make the statement, about the purpose of Rich's book is truly practical biomechanics. And it is basically mostly theory-free or theory agnostic, but it really takes you through how he thinks. So here you get the chance to view a master's thinking and what he thinks about when he's evaluating a patient, which is really important. There are some segments that repeat, but that has to be helpful to get it into your head. And then there's a lot of questions that are asked. The answers aren't always there, so it's worth reading the answer if you don't know. And you might not know, no matter how much you know. But it does take you through Rich's thinking. Biomechanics has been a very difficult to understand thing for many people. In part, I'd like to see a universal theory, but all theories have been trashed. So I'm not sure, what is left. Rich, in the beginning of his book, says that he was root trained, and there's a model. Some parts good, some parts are not valid, but at least it is a model. So I'm not sure if we're left with vibrating, oscillating parts with a balance of factors around the rear foot, by the subtalar joint axis, if that's quite enough to make a cohesive theory of how biomechanics work, which is why many people call it biomagic. Then we have criticism of the mid-tarsal joint, probably deservedly so. So this is a complicated aside, thinking about, should we view the mid-tarsal joint as an oblique and longitudinal axis, or as two separate joints that act within constraints? Are the constraints still valid? Because it has been debunked, the longitudinal and oblique axis, while we've been trying to wiggle the foot this way and that way to make it go that way. But we do seem to have some constraints about the axes of the other joints when they're parallel or when they're divergent. And then there's less motion at certain points. However, I think Rich's approach is great because it takes you through practical thinking about what do you do? As we sit there, we're not thinking about, well, this mid-tarsal joint axis is doing this or that, but we do think about things when we're casting. We want to press up under the fourth and fifth met head or just anterior to that. And as Rich mentioned in his book, Paul Scher, who I didn't know it was Paul who came up with the idea, but it made sense. I heard it first from Doug Ritchie about plantar flexing the first ray. I would look at things as going beyond root and orthotic construction, which Rich certainly did with his inverted casts, and Kevin Kirby added to it with his Kirby skives, both medial, most often used, and sometimes lateral. But looking at what is a functional orthotic, when I was in my fellowship, I was asked that question, and people meant it differently later on. The root functional orthotic was always too narrow, bisecting the first ray, bisecting the fifth ray, and having something narrow that couldn't and shouldn't support the arch. When we found out we needed to have some intersection at the talonavicular joint and meet underneath there, which Rich achieved with his inverted cast technique. But you can explain all of that. And also, if you were teaching the whole 4 years worth of biomechanics, how would you include root or exclude root? Since basically—
That is a great question.
Yeah.
That is a great question.
Sorry, the long lead up. I'll shut up now.
No, I mean, some of the issues with root are over neutral position, or was he the first? to describe something. Somebody else described it. I don't care. My inverted orthotic probably dates before Otto Schuster, but I'll give Otto Schuster the initial. He was the first person to put an inversion in an orthotic that I know of, but probably somebody else did it before him. Aristotle probably did it. I would teach biomechanics using all the theories, which is really my approach. So I hate to see people going around bashing each other. It's like I've learned, I think, just as much from Howard Dannenberg as I have from Merton Root, from Kevin Kirby is an incredible gift to biomechanics. I don't like any of these people when they go off too far, and let's learn from each other. There's only a few things that I can't learn because it's too proprietary, excuse me. So I can't get access to how they do it, but I'll, if somebody comes up with an idea, that's why I've kept a lab. I still make my own orthotics, which nobody has to do, but because I teach biomechanics, I have always felt that was my obligation to try everything from the Kirby skives to the DC wedges from Australia to whatever, and get a feel. So I would teach biomechanics from the standpoint of treating a patient, and what does the patient come with? What are the conflicting theories, and let's make an orthotic using each theory. Or let's, if you use the tissue stress theory, we don't have to make an orthotic at all. We just have to change the stresses. Maybe we can do that just for the shoe and the strengthening program. So, but that's what I would do. I mean, all the things I do in biomechanics, from my gait evaluation, which I learned at CCPM, my casting technique from CCPM, my measuring techniques from CCPM, like all those were started there because of Merton Root, founding and putting it all together for us. And whether he was the first one or whether some of his ideas were valid or not, I mean, we could spend days talking about neutral position and when it applies and when it doesn't apply to patients. I find neutral position incredibly fascinating. I've talked to orthopedic surgeon, like neutral position for a person with bow legs, like tibial varum of 12 degrees. You can only get a neutral position orthotic with an inverted orthotic. And you can save that person's knees by holding them in extreme inversion around a neutral position, which keeps the knees in better alignment. As long as when you're dealing with knees, the knee is affected by how the foot is, how the knee joint axis itself, and what the hip does. So sometimes I'm treating a knee and it laughs at what I do, and other times it responds 1-to-1. I can do 1 degree of correction at the foot, and the knee goes 1 degree in the direction I want it to go, and I go yippee. So, but that's how I would approach it. I would each.
I want to interject a couple things and then get back to Steve on what you just said. I sometimes will make an orthotic, and let's say an example of tibial varum, the riding that outside ridge, and discover that maybe they don't tolerate that orthotic as well as I would have liked. And I end up either taking a little bit off the arch on the adjustment and adding even more valgum. You know, if they're riding the outside ridge where it's a styloid process that's hurting on the fifth met, or peroneus brevis, you know, tendon type injury. And I'll find that I'll add like a 4-degree valgus or 5-degree valgus long wedge. By that I mean from heel and then transitioning in the midfoot and tapering, you know, into the forefoot, so that you don't gum up too much of the toe box area. And sometimes they'll respond more to that. And what I want to ask you, and then we'll get back to Steve, is it seems like I created a moment there, a force moment with that valgus wedge. It seems to me what I'm hearing mainly is a shift from kinematics or visual to kinetics in terms of where are we going to make the biggest delta in our patients. What is your interpretation? And again, not to trash Merton, Root, and Weed, but how do you feel about that? Kinetics versus kinematics. And I'm not saying everybody, but I'm seeing, you know, I've been interviewing a lot of people, looking at a lot of stuff, reading a lot of stuff, and that seems to me to be a trend in modern biomechanics.
I think it's all, yeah. Do you treat motion? Do you treat position? Is crucial. Are you just treating forces, which is fine. One of the biggest studies on the inverted orthotic couldn't prove that the orthotic changed anything in a runner in terms of the motion, but found that the inverted orthotic dramatically slowed down the stress on the posterior tib tendon. You know, the medial side force internally was much reduced. And that's why it helps so many people with posterior tib tendonitis, and why runners love the inverted orthotic, and for that reason. So I'm trying to change their motion, but in essence, sometimes I'm just changing the stresses through an area. And I think that's the big point that Kevin Kirby made when he said, I don't know if we need so much inversion, other than a little medial skive. Not that I should say it's a little, but we're like, let's think more about the force that we're trying to reduce over the position. With your example, Ben, it to me, you know, one of the basic principles in biomechanics is that you can't push a joint further than it can go. You could do it temporarily as a cast. So you could put that, if a patient, and this is classic root biomechanics, if a patient has 10 degrees of tibial varum and they have 10 degrees of eversion in their subtalar joint, they can only get to vertical. You know, they can't go further than that without subluxing the subtalar joint. So you can, but the same patient has all these perineal problems, lateral ankle instability, and you've got to try to decrease the stress on that lateral column, lateral ankle. So you can valgus them for a short time, but in the long run, that in that patient, you could end up jamming up the subtalar joint, which will torque their knee, and you've helped their ankle but hurt their knee and their hip and their back in the long run. So when I'm making an orthotic that I'm breaking one rule to help another, I always explain that to the patient. I said, for a while, we're going to do this, but I want to see you in 3 months. I hope you've rehabbed enough. You don't need this much valgus wedging, and I'll take you back into a more normal position. So I look at orthotics not as a one-time thing, but as a process, which I think I learned from physical therapists, but I definitely learned from orthopedic surgeons who, you go in, you snip a little of the knee cartilage, it doesn't work. 2 weeks later, you take a little more out. 2 weeks later, you know, they look at surgery as just, you know, something they do, and you know, so it's more of a process.
Yeah, I think that was an important statement that you hadn't covered yet. And that was what I was going to say next, is that you viewed, and it should be viewed, that biomechanics and biomechanical treatment is a process. So you observe, assess, evaluate, and then change your therapy over time. The other thing about what you're doing as you're speaking about inversion and skives is those two concepts have replaced a rear foot post. You know, so rear foot posts, if anyone is using them at all, it should be 0, 0. We don't need a grind off because it's ineffective, and we don't need to post it 2 degrees because you've already used this, an inverted cast and a Kirby skive in combination.
Correct.
The East Coast needs to understand that.
Yeah, yeah. All my inverted orthotics are flat, flat ground, so there's no motion put in them. Right.
Yeah, I started doing that probably about 15 years ago or so, and it's worked well.
Yeah.
Quick comment on gait analysis, which I agree with everything you said about gait analysis. I would add in 2 factors. You know, so in trying to assess for a leg length, and we see is the head tilted this way or that way, and 60% of the time it means one thing, and 40% it might mean the other. Shoulders, other impacts besides compensated scoliosis or even hip drop. You know, so we're looking at all of these things when we have 2 good things, which if you train hard enough and do it for a long enough period, you'll be able to look at, one, the peak height of the head, head bounce. How high up does the head go mid stance on the right and the left? And you can see that pretty well with whatever background you've got. And the other thing is learning to time the steps. You know, so how much time is spent on each side, and between those 2 factors can add to your assessment of functional, functional limb length difference. Certainly, I know in volume 2, the only drawback is we don't have all 4 volumes of your book.
Yeah,
so everyone has to live long enough and practice long enough.
I wanted to be invited back multiple times. That's plus I'm still working a lot more, almost full time. So it's like you write half hour here, a half hour there. It takes you a long time.
Oh, without a doubt. But again, doing the thinking process and learning the principle and realizing that it's a process, which not every patient wants to accept, but it is a process.
Rich, that's an old carnival trick. You want to, with a 4-book series, you always want to leave them begging for more.
Yeah.
So,
yeah, I hope so.
Bravo on that one.
Yeah.
Nice job.
Yeah. The one point you made, Stephen, is very true. Like, so I practice sports medicine, which is patient and doctor on the same level.
Mm-hmm.
That fits about 25% of your patients, of the people who walk through the door. About 25% of people are they are with you the first moment you start speaking, and a lot of patients are like, no, doctor, you tell me what to do. I won't tell you anything. I will just mention, maybe it's my left foot, but I can't remember if it's my left foot or my right foot that hurts. But one of those feet hurt, and please make me better. But I don't care what you do. So sports medicine approach is all about, it's following your patients. It's and a lot of changes, a lot of patients have just as much responsibility, even though your job is really not to make the patients hurt themselves. I may say, well, what I think you're doing is wrong. I probably won't hurt you, but I'd rather do this, and at least put it out on the table. And because some people will come in and say, I don't want to have surgery. I I don't want to do this, I don't want to do that. And they like tie you into a corner and say, well, that's, what am I supposed to do? So anyway.
Now, I think it was within your book or in an interview. I'm not 100% sure, and you can tell me, talking about the different phases of initial treatment, rehabilitation, and coaching. I think you may have said you like to be involved in all three.
Right. Yeah.
Okay.
I talk about the three phases
Mhm.
of the rehab process. Phase one is the immobilization, anti-inflammatory phase, which podiatrists, we're all like great
Right.
at that.
Right.
We know how to put casts on, and we know how to, have people, rest, or, this could be the theater for surgery, when somebody's in this phase. Phase two, they're re-strengthening the tissue. So they're still not ready for full activity, but it's a re-strengthening phase. And stage three is the return to activity phase, which has to, until back to full activity, it has to go very progressively, slowly. There's a lot of rules in each phase to use. So I know a lot of podiatrists who are just phase one podiatrists. I call them. That's what they want to do. If a patient needs surgery, that's fine. If they need casts, that's fine. But don't bring in their orthotics and shoes. And other podiatrists like me, I like to be involved in all three phases. So I'm more of a general podiatrist in terms of my biomechanics. I still have it's a biomechanics practice, but it's almost more like general medicine too. And I don't mind. I live in a practice that's that has the ultra rich on one side of me in Pack Heights and Nob Hill of San Francisco, and the Tenderloin, which is getting all the press, on 2 blocks away. So as long as they have Medicare, they can come in the doors, and I may have somebody who is living in their car, but just got public housing, and the next guy's the third richest guy in the world, and I tend to like the person who was homeless more. So, and I treat them all the same. I don't vary it. So I have my rules on, probably part of my religion, and like I don't undertreat people if they don't have money. So I'll just say it like that. So if whatever they need, I try to give it to them to my best.
I agree. I've always enjoyed all three phases. And like you, I found that there's a trend to keep people moving with badly injured Achilles, whereas the cast boot was very helpful. And heel lifts were out for a while. They were condemned as the worst thing in the world by someone who wrote in the New York City paper, who was not a podiatrist or even an orthopedist. But the reality was that occasionally, and actually, you and I would both see that working all the time, I have no doubt. And even the physical therapist who knew what I was going to do, immobilize the patient, sometimes they would give up and say, "Here, Pribut, you take this patient and do what you do best," which is, a removable cast boot. I think I have one question on a slightly different topic for you about treatment of, say, Helix Rigidus, which in many cases the sesamoids become involved because the bone's not gliding properly. Sometimes turf toe, but more often with Helix Rigidus, where the sesamoids are also aggravated and painful. So the two therapies that many people use, or your cardinal rule, is offload, which I like, and I usually start with that. But many people have used splints rather than the offloading. What are your comments on those two disparate methods?
Yeah, so so in general, it's, we like motion. It's definitely a sports medicine approach to painful joints, but at times you have to immobilize. So I tell my patients, like nerve pain, you have to honor the pain sometimes, and you have to almost ignore the pain at sometimes. So we try to keep the joint moving as much as we can and not just restrict the joint all the time. So I know the basic philosophy of Helix Rigidus in sports medicine is to try to do reverse Mortons when we can, but if we can't, you have to mobilize it with carbon plates and Hoka shoes and Morton's extensions, spica taping, all the things we can do very well at immobilizing it. But in the long run, we want to keep it moving as best we can. And usually you can find a good solution. If patients can't dance that, I say, if you can't figure this out, somebody's going to fuse your joint, or at least put an implant in or something like that. So let's try to learn this. And again, some of my patients will be fine with that experiment. I try to say, you're a scientist, you got to figure this out, and help me figure it out. What shoes work the best? What inserts work the best? I use a lot of adhesive felt. I mentioned that, like every podiatrist who does sports medicine should have 1/8 and 1/4 inch adhesive felt, because that's a nice temporary thing that patients, they can put on their Morton's extensions, they can put on their reverse Mortons, they can play with padding to off weight sore areas. Sometimes patients come in and what helps them is something I would have never thought of for their problem. A lot of times it's very logical, but sometimes not. So that's, anyway.
Cool. Thanks.
Well, Steve, with that last question, you've touched on something near and dear to my heart with the Helix Rigidus. I developed a turf toe splint, and I'll have to get the company OS first to send you one, Rich, to have you check it out. It's funny. I sent it over to Temple, and the Biomechanics doc, well, he's a PT that runs, probably has a PhD, that runs the clinic there. First thing he did is he took it out of the package and he bent it and he took a video and was like, what? And the point of it was more of a slow down that motion than a stop the motion. And I think if we get into a certain mode of thought, we might miss that, it's actually helping some people. Doesn't help everybody, but these are all little things that we can sort of add to the mix to our toolbox. And to the point of, your little bit with the adding orthopedic felt, what I did, I 3D printed a thin polyurethane piece, like 2 or 3 millimeters, added that on a very heavy guy to my own splint because he needed a little more rigidity. And unfortunately, I'm not in a position where I can tell the company, you know what, I'd like to have Taiwan make it a little stiffer. They're just only going to do so many iterations. That's just real life. But I can do that in my clinic, and that's what I did, and it worked. So I think that this thing of tinkering until we get it right is a relevant thing. And I would invite you both to take a look at it. And then I've certainly gained some stuff from you already. I did learned a little bit with some of your range of motion techniques, where I was just kind of going through the arc and distracting, and you showed that little up motion, a little side motion, and then a little twist motion with the first MTP. So I'll have to thank you for that. And listen, this has been a great segment. We really look forward to book 2, and I'm going to invite you back. And I think Steve would be a good person to have also for that, because of his past history crossing paths with you. So thanks again for doing this, and we look forward to book 2. When are we going to see that? No pressure, Rich. When do you anticipate having book 2?
It's done. I'm doing the illustrations. So,
oh, wow.
Well, my wife and I are walking in France for a month in September. So my goal is to have it to the publisher by the day I leave, and I'll still be on the internet, so I'll be able to make corrections while we're doing our walk. So that's my goal, is August 31st to have it to the publisher.
Well, that's going to be great. Thanks so much again for doing this, and we look forward to having you again with book 2, and maybe we'll see you in a meeting before then. You never know.
Yeah, okay.
All right.
All right.
See both of you.
Thank you.